Usually when we look at a human face, we just see this smooth, unified surface. It's kind of like looking out at a calm ocean.
Oh, absolutely. Yeah.
Like you see the gentle waves, the reflection of the sun, and you just don't immediately think about the chaotic, high-pressure currents that are moving, just a few millimeters below the surface.
Right, because we're entirely wired to see the aesthetic result.
Yeah.
Like human beings just naturally focus on the surface, the symmetry, the expression.
Right.
We rarely, almost never pause
Yeah.
to consider the complex hidden engineering that keeps all that tissue alive.
And when you think about a syringe, it's just a simple needle and a plunger, you naturally expect it to be this instrument of absolute pinpoint precision.
Yeah, point and shoot, basically.
Exactly. You point, you push, it goes exactly where you want it. It feels very binary, like the filler is either safely in the right spot or it's not.
And it is incredibly comforting to think that way.
Mm.
We want our medical tools to feel foolproof and exact.
But then you step into the world of aesthetic injectables, specifically placing dermal fillers in the face, and suddenly that illusion of simple precision just kind of vanishes.
It really does. It's a completely different reality.
We're looking at a procedural landscape that is, quite honestly, a high-stakes minefield. So welcome to this deep dive.
Thanks. I'm really excited to dig into this one.
Today, for you listening, we're exploring a highly debated, critical question in the aesthetics community. Basically, how does a blunt-tip micro-cannula, specifically the 25-gauge and 27-gauge sizes, compare to a traditional sharp needle when it comes to vascular safety during anterior wall filler placement?
Yeah, and this is just a fascinating mechanical and anatomical debate. To get to the bottom of it, we're synthesizing an incredible amount of clinical literature today.
Right, we've got a whole stack of sources here.
We really do. The data ranges from, massive retrospective database analyses of literally millions of injections to meticulous cadaveric dissections, all the way to expert consensus guidelines from leading practitioners.
So whether you're a medical practitioner looking to refine your procedural safety, or you're just, an insanely curious learner fascinated by human anatomy and physics, this deep dive is going to completely change how you view a simple syringe.
It's a game changer for sure.
Okay, let's unpack this. Before we can even compare the tools themselves, we have to understand the environment they operate in, right? Like, why is placing filler in the anterior wall of the face so incredibly risky?
Well, the best way to visualize the human face is as a densely packed, multi-layered superhighway of critical blood vessels.
Okay, superhighway, I like that.
Yeah. And when we talk about the anterior wall, which just refers to areas at the front of the face, like the lips or the piriform fossa near the nose, those blood vessels are remarkably close to the surface.
Like how close? We're not talking about deep buried arteries here, are we?
Not at all. We're talking about fractions of an inch. Take the lips, for example. The superior and inferior labial arteries, the main blood supply for the upper and lower lips, they sit just 3 to 5 millimeters under the vermilion border.
Wow. Wait, the vermilion border, that's just the exact edge where the red part of your lip meets the normal skin, right?
Exactly. And in the piriform fossa, which is that little triangular depression just beside your nostrils, you have the angular artery navigating through these very tight, restrictive tissue spaces.
3 to 5 millimeters, that is nothing.
It's practically right there. And the ultimate fear for any injector working in these delicate, shallow spaces is an event called a vascular occlusion, or VO.
Okay, let me make sure I have this straight for everyone listening. A vascular occlusion is essentially when the dermal filler accidentally enters into an artery or maybe presses so hard against it from the outside that it completely blocks the blood flow. Is that right?
That is the core mechanism, yeah.
Yeah.
And the consequences, they can escalate from concerning to catastrophic very quickly.
Because it cuts off the oxygen.
Right. If you block an artery, you deprive the surrounding tissue of oxygen. Within a very short window, that tissue can actually start to die off, which is a process called tissue necrosis.
Which sounds awful.
It is. But there's actually a much more severe scenario. If filler is injected directly into an artery under high pressure, it can overcome the patient's own blood pressure.
Wait, meaning the manual pressure from the practitioner's thumb pushing the plunger is literally stronger than the heart pumping blood through that specific artery.
Yes, exactly.
Yeah.
And that physical imbalance of force causes something called retrograde tracking.
Retrograde meaning backwards.
Exactly. The filler is forced to travel backward against the natural flow of blood. And if that filler gets pushed far enough back up the arterial tree, it can actually reach the ophthalmic artery, which supplies the eye.
Oh my God.
Yeah. Once the pressure from the syringe is released, The patient's blood pressure pushes that filler forward again, but this time it goes into the central retinal artery, and that can cause instant, irreversible blindness.
That is absolutely terrifying. I mean, it really frames why practitioners have to be so careful.
It's the ultimate worst-case scenario.
And from what I read in the sources, it's not just about accidentally poking the vessel directly. Dr. Tim Pierce, who is a leading voice in aesthetic safety, notes in his guidelines that even the sheer volume of filler you use in one sitting can be incredibly dangerous.
Yeah, that's a huge point.
Right. He advises never putting more than 1 milliliter of filler in the lips during a single session.
And whose reasoning there is purely mechanical. Like if you deposit too much filler in at once, especially in a tight anatomical space like the lip, you risk physically compressing the blood vessels from the outside.
So you're just squishing them shut.
Exactly. You essentially crush the artery closed, causing a vascular occlusion, even if the needle never pierced the vessel wall.
Wow.
Furthermore, large volumes can just distort the natural anatomy. Dr. Pierce points out that overfilling can invert the wet-dry border of the lip.
Okay, let's visualize that for a second for everyone. The wet-dry border is that transition point on the inside of your lip.
Right. So if you put too much filler in, the sheer bulk of it causes the inner mucosa, the wet, slippery part of the inside of your mouth, to physically roll outward and become exposed to the air.
Which is terrible for the patient. They end up constantly licking their lips just to keep that delicate tissue moist, which is incredibly uncomfortable.
Right. Nobody wants that.
So to avoid both the internal vascular crushing and the anatomical distortion, Dr. Pierce strongly advocates for placing microscopic volumes, like 0.05 milliliters per injection point.
Tiny amounts. So if we use a real-world analogy here for you listening, navigating this dense vascular network is literally like walking through a minefield.
That's a perfect way to look at it.
You need to know exactly how deep the arteries are buried. If you know the labial arteries are sitting exactly at that 3 to 5 millimeter depth, you basically have two choices.
You either safely tiptoe over them by staying extremely superficial, just barely under the skin, or you have to crawl strictly beneath them, sinking your instrument all the way down until it rests firmly on the facial bone, the periosteum.
Exactly. You're either entirely above the danger zone or entirely below it.
The middle ground is where you get blown up.
Yeah, that 3 to 5 millimeter depth, that middle ground, is where catastrophic injections occur.
Which brings us to the tools we use to navigate this minefield. If the face is packed with hidden high-pressure blood vessels sitting just millimeters under the skin, why would anyone choose to navigate it with a sharp cutting tool?
It sounds counterintuitive, I know.
Let's look at the traditional sharp needle. What are the actual clinical pros of using a needle?
Well, the advantages of a sharp needle revolve entirely around precision and tactile feedback. A needle allows an injector to deposit a microbolus of filler in a highly specific location.
Because it just goes exactly where you point it.
Right. Because it's sharp, it passes through the layers of skin, fat, and muscle with minimal tissue displacement. And crucially, when the practitioner is aiming for that deep, safe plane beneath the arteries, a sharp needle allows them to easily reach the bone.
They can feel it.
Yes. When the metal tip hits the periosteum, the injector can feel a distinct hard stop. It provides a really definitive sense of depth.
But the cons seem incredibly glaring here. Needles act like microscalpels. They don't nudge tissue aside, they just effortlessly slice right through it.
Yep.
And that includes slicing right through blood vessels.
The microscalpel effect is the fundamental danger. And this is where the University of Amsterdam cadaver study becomes incredibly illuminating.
Oh, this study was fascinating.
It really was. The researchers wanted to see exactly where filler ends up anatomically when injected with a needle versus a cannula. So to do this, they injected brightly dyed filler into fresh cadavers.
Just to track it perfectly.
Right. Then, they meticulously dissected the tissue, peeling it back layer by layer to trace the exact physical path the filler took.
And here is where it gets really interesting for you at home. They found that even when a practitioner does everything right, meaning they push the needle all the way down until they feel that hard stop on the bone, supposedly crawling completely beneath our imaginary minefield, they can still accidentally inject directly into an artery.
Yeah, which seems impossible, right?
Exactly. How is that physically possible if the needle is resting on the bone?
Well, it comes down to the microscopic geometry of the needle tip. A hypodermic needle isn't just a flat, hollow tube at the end. It features a bevel, which is a long angled cut that creates that sharp point.
Okay.
So the Amsterdam study demonstrated that even if the very microscopic tip of that bevel is scraping firmly against the bone, the opening of the needle is elongated.
Oh, I see.
That means the upper half of the bevel can still be sitting perfectly inside the lumen, the hollow center of an artery that runs just above the bone.
Wow. So the needle is essentially existing in two different anatomical planes at the exact same time. The tip is in the safe zone on the bone, but the actual opening where the filler comes out is in the danger zone inside the artery.
Exactly. The injector believes they're safely depositing filler on the periosteum because they feel the bone, but they are simultaneously pumping a viscous gel directly into the bloodstream.
That's crazy.
It gets worse. Furthermore, the meticulous dissection in the Amsterdam study revealed another phenomenon called retrograde tracking along the needle path.
Wait, is that different from the retrograde blood flow we talked about earlier?
Correct.
The thing that causes blindness?
Entirely different, because the sharp needle creates a clean vertical surgical channel through the tissue. The injected filler doesn't always stay neatly pooled at the bottom where you put it.
Oh, so it comes back up.
Yeah. As the practitioner pushes the plunger, the path of least resistance for that filler is often straight back up the tunnel the needle just created. The filler leaks backward along the outside of the needle shaft, migrating up into those dangerous superficial layers the practitioner was actively trying to avoid.
Okay, but let me push back on this a bit. If a practitioner is using a needle, they're trained to do something called aspiration. Right.
Right. Aspiration is a standard teaching.
They pull back on the plunger of the syringe to create a vacuum before they actually push the filler in. So if the tip of their needle is sitting inside a blood vessel, they should see a flash of red blood enter the syringe. Shouldn't that simple safety check make needles perfectly safe?
I mean, aspiration is a practice that sounds foolproof in theory, but the clinical studies tell a very different, highly alarming story. The prevailing expert consensus, backed by rigorous data, is that aspiration is dangerously unreliable.
Why is it unreliable? It seems like basic plumbing. You pull a vacuum on a pipe, fluid should come out.
Let's examine a pivotal study by Van Loghem. They tested aspiration in a controlled clinical setting and found that the rate of false negatives, meaning the needle is absolutely in an artery, but no blood enters the syringe, is astronomically high.
Why doesn't the blood come out?
Well, to get a reliable blood flashback with the thick fillers we use today, the practitioner often has to hold that negative suction pressure on the syringe for a full 10 seconds.
10 seconds. I want everyone listening to just count to 10 in their head right now. 1, 2, 3. Like, if you have a sharp metal needle buried deep in someone's face, near their nose or lips, holding it perfectly, microscopically still, while pulling back on a stiff plunger for 10 full seconds seems clinically impossible.
It is. The patient would twitch, they would breathe, or your own hand would shake.
Exactly.
The real-world application of a 10-second hold is practically impossible. But the mechanical failure of aspiration goes even deeper. A fascinating study by Moon and colleagues tested aspiration using animal models, specifically rabbit femoral arteries, which closely mimic human facial vessels.
What did they find?
They found that if the needle is already primed, meaning the practitioner has already pushed a little filler through, so the shaft of the needle is full of thick, viscous gel, pulling back on the plunger rarely produces a blood flashback at all.
That makes total sense if you think about it. It would be like trying to suck a thick, frozen milkshake through a tiny cocktail straw.
That's a perfect analogy.
The filler is just too dense and heavy to allow the thin liquid blood to travel up the needle under normal manual suction pressure. So a practitioner pulls back, they see no blood because the needle is plugged with filler, they assume they're totally safe, and then they push forward and inject directly into the artery.
Exactly. Aspiration can provide a massive false sense of security. The practitioner believes they've cleared the safety check, which might actually embolden them to inject faster or with larger volumes.
Wow. So needles effortlessly slice through vessels. They can exist in two anatomical planes at once, and the ultimate safety check, aspiration, is deeply flawed. It makes total sense why the aesthetic world introduced the blunt-tip micro-cannula.
It really was a necessary evolution.
Let's transition into this tool and how it supposedly solves these massive problems. What exactly is a micro-cannula?
A micro-cannula looks somewhat similar to a long needle, but the fundamental difference is at the tip. The end is completely rounded and blunt, acting almost like a tiny probe.
So how does the filler get out?
The filler doesn't come out of the tip. It extrudes from a small port on the side of the shaft. Because it's blunt, The mechanical theory is that it glides through the soft tissue planes rather than slicing them.
Nudging things out of the way.
Right. Instead of cutting through blood vessels like a microscalpel, the rounded tip physically nudges the elastic vessels out of the way.
And the safety data backing this up is staggering. We have to talk about the massive study published in JAMA Dermatology by Allam and colleagues. They analyzed an astounding 1.7 million filler injections.
Yeah, when we look at clinical literature, a data set of that magnitude is almost unheard of for cosmetic procedures.
It's massive.
The scale of that study allows us to see undeniable statistical truths. The researchers aggregated data across a massive network of practitioners to compare the adverse event rates of needles versus cannulas, and their findings were definitive. They concluded that using a cannula reduces the risk of vascular occlusion by a staggering 77%.
77%? Oh, wow.
To put that into a clinical perspective, they observed one occlusion in every 6,410 procedures performed with a needle. When practitioners used a cannula, that risk plummeted to just one occlusion in every 40,882 procedures.
That is a life-changing risk reduction for patients. And beyond just preventing blindness or tissue death, there are secondary cosmetic benefits too, right?
Oh, absolutely.
Because a cannula is long and somewhat flexible, an injector only needs to make one tiny entry hole with a sharp needle to access the skin. Then they slide the blunt cannula into that hole and can thread it around to treat a huge area of the face from that single pivot point.
Exactly. And fewer entry points mean drastically less trauma and bruising.
Oh.
Dr. Zipperstein's guidelines highlight this beautifully.
Yeah, I saw that.
She notes that in highly delicate vascular areas like the tear trough, right under the eyes, severe bruising drops from somewhere between 5 and 50% when using needles, all the way down to just 1% when using cannulas.
Down to 1%. That's incredible.
It drastically improves the patient experience.
Yeah.
Less pain, virtually no bruising, and significantly less social downtime.
Okay, but I have to play devil's advocate here for a second. Let's think about the actual physical action of using this tool. If a cannula is totally blunt, it cannot effortlessly slice through the tissue like a needle.
Right.
Doesn't that mean the practitioner has to push much harder to force it through the face? And if you're applying more physical pressure, pushing a blunt rod through tissue, couldn't you just accidentally create a battering ram effect and burst right through an arterial wall anyway?
That is the exact mechanical reality we have to address, and it perfectly tees up the massive debate in the aesthetic community between using a 25-gauge cannula versus a 27-gauge cannula.
So size matters here.
Hugely. Your intuition is correct. Cannulas are not magic bullets. We have to look at the fluid dynamics and the physics of how they interact with human tissue. Let's apply the Hagen-Poiseuille principles from physics.
Okay, lay some fluid dynamics on us. What does Hagen-Poiseuille tell us about injecting filler?
In fluid dynamics, this principle explains the relationship between pressure, fluid viscosity, and the radius of a tube. Essentially, the narrower the tube, the exponentially higher the pressure required to push a fluid through it.
Makes sense.
And in the medical world, gauge sizes are counterintuitive. A 27-gauge cannula is significantly thinner and narrower than a 25-gauge cannula.
Right, higher number means thinner needle.
Exactly. So if you're trying to push a thick, highly viscous gel like dermal filler through a very narrow 27-gauge tube, the Hagen-Poiseuille principle dictates that the practitioner has to apply significantly higher physical pressure to the plunger of the syringe.
So the injector's hand is working harder, pushing with more force, which just inherently makes the whole instrument less stable.
Exactly. And what a pivotal study by Pavicic discovered about these finer 27-gauge cannulas is honestly alarming. They set up a mechanical model to measure the exact amount of physical force required to penetrate an arterial wall.
And what did they find?
They found that a fine 27-gauge cannula requires almost the exact same amount of force to puncture an artery as a 27-gauge sharp needle.
Wait, really? So if you use a cannula that's too thin, it completely loses its blunt safety advantage. It essentially behaves just like a sharp needle.
Physics dictate it, yeah. Because the tip of a 27-gauge cannula is so small, all the force the practitioner applies is concentrated into a microscopic surface area. That concentrated pressure allows the supposedly blunt tip to easily pierce the elastic vessel wall.
Wow.
This is exactly why most safety experts strongly recommend using a larger 25-gauge cannula. The larger surface area of a 25-gauge tip spreads the applied force over a wider area, making it significantly harder to accidentally puncture a vessel.
It's the difference between stepping on someone's foot with a stiletto heel versus a flat sneaker.
Yes, great analogy.
The stiletto concentrates the force and pierces. The sneaker spreads it out and nudges. But there is a fascinating counter-argument to this in our sources, and it comes from Dr. Saperstein.
She brings up a really interesting point.
She actually argues that in highly delicate areas, like the tear troughs under the eyes, a highly elastic, blunt-end 27-gauge cannula might actually be the superior choice. Why would she say that after we just learned how dangerous they can be?
Her reasoning introduces a critical human element into the physics equation. It all comes back to tactile feedback. She argues that because a 27-gauge cannula is so fine and highly elastic, it acts almost like a sensory antenna for the injector.
A sensory antenna.
Yeah, when that thin cannula bumps against a blood vessel, the injector can actually feel the subtle elastic resistance of the arterial wall. It transmits that physical bump straight back up the shaft to the practitioner's hand, allowing them to instantly stop and redirect the instrument.
Whereas with a massive, stiff 25-gauge cannula, you might just bulldoze right through the tissue like a tank, completely crushing a vessel without feeling a thing. And with a sharp needle, you slice through it so smoothly there's zero resistance anyway.
That is the core of her argument. But relying on that incredibly subtle tactile feedback requires a highly experienced injector. You have to know exactly what the microscopic resistance of different tissue planes feels like through a metal rod.
Which brings us to the dark side of cannulas. And this is a severe warning brought up in the literature by Dr. Tim Pierce and Dr. Tansitit. We've clearly established that cannulas reduce the absolute frequency of vascular occlusions by 77%. But what happens when a cannula does breach a vessel and cause an occlusion?
This is where the mechanical differences become truly terrifying. If an injector makes an error with a sharp needle and hits a blood vessel, the needle usually pierces straight through one side of the arterial wall and right out the other side.
I picture it like shooting a sharp dart entirely through a plastic water pipe. It makes a tiny hole on the way in and a tiny hole on the way out. You get two small leaks, maybe a microscopic droplet of filler gets left inside the pipe, but mostly you've just pierced it and moved past it.
That is an excellent visual. But a cannula interacts with the vessel entirely differently, because the tip is blunt. If it does manage to breach the vessel wall, perhaps the practitioner applies too much force right where an artery branches or curves are tying of them. It rarely pokes out the other side.
Where does it go?
Instead, the blunt tip enters the vessel, and then it naturally tracks parallel inside the lumen. It slides right down the interior of the artery.
Oh, man. So if a needle error is a dart shooting straight through a pipe, a cannula error is like threading a long snake directly into the pipe, slithering right down the center plumbing system.
It's a catastrophic scenario. If the injector doesn't realize their cannula is now resting comfortably inside the artery, they will begin to inject.
And since they're using a cannula, they're probably injecting a lot.
Exactly. Because cannulas are specifically designed to lay down long, continuous threads of filler across large areas of the face, the injector is usually pushing a very high volume of product as they slowly pull the cannula backward.
Oh, no.
In this scenario, they are unloading a massive, continuous tube of filler directly into the bloodstream. This leads to severe, massive occlusions that are incredibly difficult to reverse, and it vastly increases the risk of that high-pressure retrograde flow reaching the eyes.
So what does this all mean for you, the listener? We've dissected massive database studies, fluid dynamics, tissue resistance, and some completely terrifying worst-case plumbing scenarios.
If we synthesize all of this clinical data, the core takeaway is absolute. The needle versus cannula debate is not a binary choice of dangerous versus safe.
Right, it's nowhere near black and white.
Not at all. Using a 25-gauge or 27-gauge cannula significantly lowers the frequency of vascular occlusions. The 77% reduction in risk is statistically undeniable.
But the severity changes.
Exactly. Because of how they behave mechanically inside vessels, cannulas can drastically increase the severity of an occlusion if they're used blindly or with too much force. Ultimately, tool selection is secondary.
The tool isn't everything.
Right. The true lifesavers in aesthetic injectables are a profound three-dimensional knowledge of anatomy, meticulous depth selection, and consistently utilizing slow, low-pressure injection techniques, regardless of what is on the end of the syringe.
That makes total sense. For you listening, if you're sitting in the practitioner's chair getting a treatment, or you're the one holding the syringe, you now know exactly why a provider chooses a specific tool.
You're not just guessing anymore.
You understand the intricate fluid dynamics, the physics of tissue resistance, and the microscopic anatomical dance happening just beneath the skin. You know why they might switch from a needle on the bone to a cannula under the skin.
It completely reframes how you look at the procedure. It transforms it from, a simple beauty treatment into an exercise of incredible anatomical respect.
It really does. And to end today, I want to leave you with a provocative thought to mull over. We've spent this entire deep dive talking about how both sharp needles and blunt cannulas ultimately rely on human touch, blind tactile feedback, and basically hoping you don't hit an unpredictable facial variation.
Lots of hope involved, yeah.
Could the future of filler safety render both of these manual blind techniques entirely obsolete? Like, will real-time visual technology, say, ultrasound-guided injections, soon transition from being a niche luxury safety measure to a mandatory global standard?
It's a huge question.
Imagine if practitioners didn't have to guess where the mines were buried in the minefield because they had high-definition sonar to see them perfectly before they ever touched the plunger.
That is absolutely the frontier we are approaching in aesthetic medicine.
We started by comparing the face to a calm ocean hiding chaotic currents. Maybe soon practitioners won't have to dive in blind anymore. Thanks for joining us on this deep dive. We'll see you next time.